Dr. Ramakant Deshpande, who's the Executive Chairman of the Asian Institute of Technology, and Dr. Viral Desai, who's a cosmetic and plastic surgeon, also on the panel, ladies and gentlemen. Since this is a topic I'm deeply passionate about, I asked to take on the discussion myself. And I hope it do it justice, because it's of relevance to all of us in this room. And speaking of relevance, and I pose my first question to the entire panel, ladies and gentlemen. When we talk about technology permeating the health ecosystem, the health tech ecosystem, the healthcare ecosystem, the medical ecosystem, a lot of times we hear that we're bridging affordability gaps. We are bridging accessibility gaps. But nowadays, when I approach a medical professional, even for the most routine of issues, I'm often told you're blessed to be treated by us because the next generation of doctors will be ChatGPT doctors, and their hands-on experience, knowledge, and ability to essentially alleviate the patient's condition is going to be drastically compromised. I'd love the panel's take on this particular statement. Does it hold truth? Does it hold relevance? And I'll start with you, Dr. Velumani.
Changing is fast, and especially last 30 years have been internet driven, and last 10 years have been Instagram driven, and last 1 or 2 years it has been ChatGPT driven.
ChatGPT driven.
And I never expected ChatGPT will occupy so much in the not only younger generation, even I am a huge consumer of ChatGPT. But having said that, it helps to not to keep unnecessary data in memory. Recall it comes. And intelligence it doesn't have. To that extent, one can fully trust it, use it. So I think it facilitates, it gets you to deliver better, know more, but still you need to do the job of concluding, decision making, and actionables. I don't think that can be done by the AI or ChatGPT. I think for the last 2 hours I've been hearing AI comes, AI will take away jobs. And I think in 1980, State Bank of India announced, Chairman of State Bank of India announced, he will buy 10,000 computers. All the staff went on a strike for 2 days. Fast forward, in 2025, if they tell all computers will be taken out, I think everybody will commit suicide. So to that extent, AI also will going to occupy such a vital position. And I believe, as earlier panel somebody was telling, if you understand it, you will lead it.
Fair enough.
And if you don't understand it, you will follow someone else. So that's how it is supposed to be. Be there and learn it fast, adapt it fast. I believe AI will improve efficiencies, will improve productivities, will improve profitabilities.
Dr. Velumani, I think thank you for setting that context, and you've answered the question directly, very directly, a bit diplomatically, but directly. So I'm going to take it to another layer and peel back another layer of the onion, and I'll come to you now, sir. It's the same question, but also answer by saying, if you were a patient, would you prefer to be a patient today? Or would you prefer to be a patient, 25 years into the future? When would you be in better, more capable hands?
Would I prefer to be a patient today, or would I prefer to be a patient 25 years back? I think
or 25 years from now, in the future.
Or 25 years ahead. Well, I can't really foresee so much in the future because I don't know. I mean, I hope that they don't make euthanasia as a compulsory thing. But 25 years back or now, yeah, definitely today, because technological advances have gone so far ahead that your diagnosis is faster, your treatment is much better, your cure rates are definitely better, your quality of life is much better, your affordability is better. So I think there is no question that, things are definitely getting better. And jokes apart, I think 25 years later, the things are anyway going to be definitely be much, much better, because science will advance to a level of, particularly in my field in oncology, the ability to predict whether a person is going to get cancer or not, then ability to manipulate. You know, there are
Right.
technologies called CRISPR technologies where you can actually manipulate the genetic structure itself and prevent a malignancy from occurring. That will go 100 times better. And so I think 25 years later will definitely be, if
So
I
your
can choose.
optimism is very heartening to hear. And I'm going to, play devil's advocate for a moment coming to you now, Dr. Viral, because the fact of the matter is that many sort of untrained professionals that are not quite prepared for the rigors of, the healthcare ecosystem and its realities are now entering the field. And technology is perhaps not exactly coming to the rescue, but becoming a crutch. Right? So do you share the same sentiment with our other two fellow panelists, or do you lean more on the side that I've just outlined?
It's a very interesting point and a point for discussion that you have put in, because when I'm basically a plastic surgeon doing mainly aesthetic work, and if you see in our field, especially aesthetic, there are lots and lots of unqualified people. Every day when we open the paper, I think there was recently a headline article on the same thing, beauty clinics, which are actually run by businessmen, not even qualified doctors. We've had this incident in Pune, in the recent hair transplant deaths in Kanpur. So when you talk about this field, yes, a lot of unqualified people. And we've been reading about them since so many years. There were some scientists who were practicing like oncosurgeons. We've had incidences like that. So of course, people talking about curing, a block in the heart by just some liquid which they give and things like that. So especially our field has been infiltrated by unqualified. How will AI help there? It's a double-edged sword. With the use of marketing, they actually promote themselves also to be specialists.
Right.
Okay, it's a double-edged. So that's one problem. The other way where it can help, where you can actually find your doctor, you can see what his qualification, registration number is. So if we are able to integrate these things, how you have, it's a far-fetched thought, but an Aadhaar card for everybody, for every human. Why not have something for every doctor, and in one click or in one thing, you know exactly what his qualifications are. Is he registered? Is he unregistered for that matter? Is he registered with NMC or MMC or any kind of government agencies? Or is he just claiming to be X, Y, Z, A, B, C, D from UK or whatever, So maybe this is where it can come in, where it can educate the patient. So I don't know, this is a thought.
Absolutely. I think you've answered both sides of the coin. And if I were to switch gears for a moment, oftentimes, as patients, what we look for in a doctor or a healthcare ecosystem is not simply the technical knowledge, but that bedside manner. All right? And that's something that perhaps, AI may or may not have the answers to as patients on the receiving end of trying to research a doctor. But Indian medical professionals have long been appreciated for their technical prowess. But sir, when it comes to bedside manner, for example, do you believe that in medical education or medical practice, there needs to be a greater emphasis on that and not so much of the stressors, such as, for example, the 1 to 1500, doctor to patient ratio and all of the things that take away from that bedside manner and that seamless caring delivery of healthcare, sir? I'll start with you, Dr. Velumani.
Actually, there is a pyramid of rich and poor. And there are a pyramid of intelligence also playing a role. There is a pyramid of hospitals in occupancies. There are some hospitals where patients are not having bed and the patients are sleeping down. And there are good number of hospitals where the security staff is sleeping in the bed of the patient. So there is a huge demand supply, identifying where I can go, who is qualified. It's a huge confusion as of today. I think some kind of standardization, some kind of accreditation, some kind of minimum essential things, if it is managed, this demand supply lopsided will not happen. That's one thing. The second thing is, India is a huge country and इधरी population इतना बड़ा है और जिस भी business में scale ही scale है उस बिजनेस में हिंदुस्तान ही मैदान है. So I believe it's going to be India leading the
Huge
world.
round of applause. How lovely.
And I believe I am limiting myself to pathology industry. I believe 25 years back, pathology tests were much high cost comparatively. And then for the last 15, 20 years, it has come down. I believe even in radiology, a standing machine is a liability and a running machine is an asset. And for your kind knowledge, on an average, 17 hours, 18 hours, the CT machine, MRI machine and PET CT machine are standing, not working. And if Indigo makes an 4,000 crore per quarter profit, that is because their flights are always on the air, not on the ground. We need to understand how to optimize efficiencies and produce solution, because Indians cannot afford per capita income of $3,000 to $3,500. I think working on efficiencies and producing volumes and giving solution will be aided by AI also.
Well, sir, Dr. Deshpande, yes, please we keep the applause coming. I think some brilliant points here. And coming to you now, Dr. I would love for you to comment on some of Dr. Velumani's, inputs. And do you believe that health insurance can plug some of those gaps? Because insurance penetration rates in this country are abysmal. They're shy of 5%, sir, and largely dominated by the life insurance sector. And, Vineet, who was here from HDFC Life, and I had a detailed conversation on that same subject. So is that the stopgap?
See, when you try to find out an answer to a question, you should always look for it somewhere else in the world, right?
Right.
So now let's take the developed countries. One is England, second is US, third one is Canada, all right? Now, England, you have a combination of private as well as insurance, right? The National Health Scheme, the NHS, is a complete insurance one, where you get a difficulty in passing urine because of a enlarged prostate today. Well, you will be operated 2 years later. So that is a kind of insurance thing that it looks for. If you want to get operated immediately, yes, you spend thousands of pounds and go to the Harley Street and get it done. So it has not sorted out the problem. Go to Canada, there is no private work there. You can't really go to a private practice person. It's only compulsory insurance.
Right.
Now, again, the same problem. You go with a headache, they'll say, okay, you go to your general practitioner, then let the general practitioner refer you to the specialist, and then you will see about it, which is again 2 months later. So it's not a happy system again. US has got both the system. 30% of US is not insured at all, which means that if you meet with an accident, you will be treated immediately and freely. But if you don't have an insurance, and if you suffer from a chronic disease, then there is a problem. Right. See, 70% of personal bankruptcy in the United States is because of expenses related to illness. So, you don't really have insurance as something which will guarantee that all kinds of shortfalls can be actually covered. And obviously, India is not nowhere in the scene where you concern that. We have schemes like the PMJs and all that, which is very nice because 50 crore people covered, then another 8-10 crore covered in old people and all that. When you start analyzing it, when you start microscopically analyzing it, it appears more like a patchwork, with very well-intentioned patchwork, but it's a patchwork. It will not really take care of major illnesses. It will not cover his expenses, my expenses, or his expenses
right.
to the fullest extent, okay? And I'll tell you one thing, here is somebody, he's an amazing man, Dr. Velumani, I'm a great admirer of him for some simple reason.
Sir.
No, it's not because, he's a creator of ThyroCare, and he started it as a lab working for 16 hours. How did he actually break the ceiling of costing? This is the cheapest kind of a lab which gives your reports accurately at the lowest cost. How did he do that? He worked out the maximum capacity of his machine. Okay, this machine can actually do 1,000 tests per day. I'm doing only 100 tests a day. So he said, no, I will do 1,000 tests per day. So how much is cost where I can go down? And suddenly he realized that in place of 10 rupees, I can charge only 2 rupees for this. And he actually did that. I'm sure he took a big hit in the initial few years. And I read about his article long back when I was still in Tata Memorial Hospital. But this is something which is a very, very innovative kind of a thinking. So will insurance plug these kind of problems in taking care of healthcare? Unlikely, but there are ways of doing it. One is public-private partnerships where you can know there are so many institutions. You know, the Brits, we keep on cursing them, but they did one good thing. They put infrastructural hospitals everywhere. They're all lying there, the primary healthcare centers, the regional centers, everything. They're still lying there. They don't have any medicines there, nothing like that. But understand one thing. If doctor wants to put up a hospital today, what is the biggest bottleneck? It's the real estate and the structure and the way the whole thing has been planned. It is all there. So the government has to just look into that, and then it can say that, all right, I will give you this particular thing. Treat your patient 60% or in whatever rate you want, provided you give me 40%. And there you can actually do this thing. And then maybe support him a little bit. So you need a little bit of an innovative thinking, and you need somebody with a hunter like Dr. Velumani sitting on the top of the guide. So it's possible to do it.
So thank you for that candor and that color to the conversation. And I think when one medical professional so openly admires another, it's just an incredibly heartening feeling. So huge round of applause for that, ladies and gentlemen. And I want to take the conversation and now come to you, Dr. Desai, because when we talk about health insurance vis-a-vis plastic surgery, right? Plastic surgery is often looked at through sort of a single lens only. These are surgeries that one opts for, one elects for. It's not medically necessary. It's a play on vanity. The list goes on. And yet, what often goes unnoticed are the fact that, look, first of all, it's a person's choice. Second of all, there are countless examples, for example, burn victims or children born with, cleft lips, so on and so forth. In which case, who are we to say that this is a medical sort of surgery or option that is unnecessary? It's not medically necessary. That's a very fine line when you go down that road. So vis-a-vis your industry in particular, how do you think about health insurance and what it can do to either help your industry grow and whether it belongs there in the first place?
So actually, I would just make a tiny correction there.
Please,
Plastic surgery is a very large field. Plastic surgeons is the only super specialty which practically operates from head to toe on every single part of the body, okay? Sure. We cover everything. We have, right, from onco reconstruction as a subspecialty to burns, to trauma, microvascular, maxillofacial, craniofacial, and of course, aesthetic is a part of it. So when you necessarily say plastic surgery, except aesthetic, the one which I'm actually more into,
right.
The rest is covered by insurance. The rest is taken care. So when you talk about cleft lip palates or you talk about burns, those things are primarily covered. Yes, but once the burns becomes old and you need some kind of they label it as a cosmetic reconstruction, then it's not covered, which it should be. Now, interestingly, in Canada and UK, a female who's having very large breasts, because it causes backache and neck ache, and she, because of that, she faces a lot of problems. The insurance actually covers these surgeries, but it's not so in India. So somebody who goes in for a nose surgery, it's always looked at, is he doing it for breathing difficulty or for aesthetic reasons?
Right.
So it's a combination. Often it's a combination in most of the cases. So obviously those kind of surgeries do need to be covered by insurance. To a large extent, some of them are, to some extent they are covered. Like I said, in many countries they're covered. But otherwise, yes, aesthetic surgery, if somebody is going in for a liposuction or a body contouring, or somebody is going in for a breast implant or a hair transplant, if I think insurance starts covering all those, I'm sure all the insurance companies would go bankrupt very soon. So those have to be considered as something which you're going to make yourself better. But do you say when somebody has a female or even a male for that matter, has a large mole on the nose and it does create problems? Is it, or a big pigmentation patch? okay, a nevus of Ota, whatever you call, or very, very deep scars, are you going to really call that aesthetic? That's a very fine line there, okay, because that will hamper their overall appearance, their confidence, depending on what field they are, if the perspective of marriage, it's a big thing in India, because I see this daily in my practice. Okay, this is happening, that's why the marriage problem, he's bald, that's why. Unfortunately, we don't want to hear this, but we hear this. So then what happens to those fields? So that's where the gray area comes.
Thank you for sensitizing the conversation. I really do appreciate that. And Dr. Velumani, coming back to you, and I'll pose this question to all of my panelists by way of a final question. So India is increasingly being touted as the world's next medical tourism hub, medical tourism capital. Irrespective of what you need, India will meet your needs. All right? So can you walk me through, for that sort of vision to accelerate, what's required, and what's required by way of the public sector and the private sector better working in tandem? Because given the positions the three of you are in, I think you're uniquely positioned to answer the question.
Right. There are some super specialty hospitals in the country which are much superior than what solutions Western world can provide. And they are yet 1/4 or 1/5 of the cost of what they can get from there. So this is not properly marketed. And probably some hygienic discomforts are there, but that can be improved. India is going to be a tourist destination, medical tourism, that's certain. Scale hi, kale hai. I keep on telling that because the scale only makes the total difference. My peers were doing 100 tests per day, and I was doing 100,000 tests per day. And I was the most powerful player. In the entire world, India is cheapest in healthcare. In the entire India, I was cheapest, and my balance sheet had a 40% EBITDA. So which means it is nothing but build volumes, price low, and build efficiencies. So that will happen in every specialty. I see some Coimbatore hospitals, which is there in tier 2 towns, is doing too good medical tourism. I think centers of excellence is needed, proper marketing is needed. We will be able to truly provide world-class service at affordable cost. What has gone wrong with Western world is cost of the insurance premium is too high. The cost of services are too high. They are around 17-18% of GDP. They are still struggling. We are hardly 2 to 3% of the GDP. We are still probably growing. I think when 50% of the population get insurance policies done for them, India will do the best.
Phenomenal to hear that. Yes, please. And coming to your closing comments now, Dr. Deshpande.
See, yes, it's right that 1.6% of GDP is actually assigned to health by the government. But if you really see the amount of money which has been assigned by the private sector to it, it gets added by another 4%. So we're somewhere around 6%. You can't compare it with the US because US is 16%. So you will never be able to compare with that. As far as good quality of education to the students is concerned, unfortunately, what has happened is medical education also is becoming more of a business. So, to get a license, to start it off, take donations, and to ensure that, they get into this graduation is something which is basically a business. And at the risk of touching a very, very sensitive topic, these reservations have again destroyed the fabric. So it should not be done that. You know what happens is, don't shift the goalpost. You can give everything to people who are deserving. Low economic status, backward caste, everything. Give everything. Free books, teaching, coaching, give everything. Don't change the goalpost. Which means that a graduate from Bihar has to appear for the same examination that a graduate from Mumbai will appear. He will face the same examiners, he will face the same questions, and he will be tested on the same kind of a character.
Brilliant. Absolutely brilliant. Coming to you now for closing comments. Sir.
Actually, yeah, he did touch a very sensitive topic about reservation. And, in medical field, when you have 65% reservation, and, you struggle, one single mark can decide whether you get MBBS or you do not get. On that note, MBBS in India is considered to be the toughest course to pass. Okay, the kind of education and the way you have to go through it, it's the toughest. So one mark decides that. And when you're struggling between the 97 and 98, and then you have somebody with 38 who comes and gets a seat. So yes, it becomes a very touching topic. So yeah, I think when you talk about patient care, health care, at some point reservation is a problem. But otherwise, besides that, going back to the tourism factor, now we're talking about Turkey, we're talking about Bangkok. They do seem ahead of us in tourism. I think one is infrastructure. Second thing is the marketing. And thirdly is, I think, the government initiatives. And especially that I've seen for Thailand and for Turkey, they do a lot of initiatives. Turkey does that a lot for rhinoplasties, hair transplant. Bangkok does a lot of the tourism for sex change surgery. In fact, it's the sex change capital of the world. Are Indian doctors inferior? No. More than 40% doctors who are present in the US or in UK are Indian, are basically Indian studied, Indian educated, and they have actually migrated there. So is there the trust? Even if you go in UAE, you ask patients there, most of the times they prefer to go to Indian doctor as vis-a-vis some other country. So I think once India masters the way to market it, and with a lot of government initiatives, Indian tourism market can go just sky high. There's no limit to it. And why should we even be number 2 for that matter? We have to be number 1 in all those fields.
All right. Well, with a highly distinguished panel like this leading the charge, there's no way we won't be number 1. So huge round of applause once again, ladies and gentlemen, for our highly distinguished panel, Dr. Velumani, Dr. Deshpande, and Dr. Desai. Thank you for doing the conversation justice.